Now the most important is pharmacological actions, or we can say pharmacological effect of glucocorticoids, or we can say adenocorticoids on metabolism. As we know that glucocorticoids are responsible to manage the metabolism. So what is the pharmacological effect of these steroids on the metabolism? On protein metabolism, it is responsible for the catabolic or anti-anabolic effect. Catabolic means degradation, breakdown, effect in lymphoid and connective tissue, skin, skeletal muscle, and the bone. And therefore, it is responsible for the weakness and thinning of the skin, skeletal muscle, wasting, and osteoporosis. So, if anyone using this steroid for the long term, external use of the steroid for the long term, it may responsible for the osteoporosis, breakdown of the bone. The bones are very easily able to fracture. So catabolic, we know that catabolic means the breakdown, catabolic effect on the bone, and which is the osteoporosis in Cushing syndrome. Major limitations in the long-term therapeutic use of glucocorticoids. So the use of the long-term steroid will responsible for the breakdown, catabolic effect in the connective tissue, skin, skeletal muscle, and the bone. What is the effect on the carbohydrate metabolism? Increase the gluconeogenesis. Gluco means glucose, neo means new, genesis means the formation of new molecule of glucose. What happened? It decreased the peripheral uptake of glucose. If the uptake of the glucose muscle is decreased, glucose is not able to utilize by the muscle. Where is the glucose? So glucose is in the blood level of the glucose will increase, and this, if the blood level of the glucose is increased, this receptor stimulated to increase the insulin release. Insulin release increases. So this is the effect, long-term use of the glucocorticoids on the metabolism. What about the fat? Increase the lipolysis. Lipo means lipid, lysis means breakdown of the lipid by stimulating hormone sensitive lipids, which is results in increase in the plasma free fatty acid. Insulin release is increase, which is responsible for the lipogenesis. Genesis means formation of the lipid, and this lipid is responsible for the redistribution of the fat in the face. If you see the diagram, this is the deposition of the fat in the face, and we can say moon face. We can say moon face. And in the neck, if there is a lipids are deposited in the neck, the condition is called buffalo hump. And if it is deposited in the abdomen, we can say truncal obesity. We can say truncal obesity. So these are the pharmacological effects of the glucocorticoids for long-term use, which is taken from the outside, but not by the endogenous. If it is released naturally in our body, if it is released naturally in our body, it will not causes these abnormalities. This is the Cushing syndrome. Cushing. Why it is called Cushing syndrome? Because the cushion, according to cushion, and cushion is soft. Because the deposition of the fat, it is termed as Cushing syndrome. What are the problem with the what are the clinical features of this Cushing syndrome? Red cheeks, if you see, the cheeks are red. Moon face, osteoporosis, the bones are fragile, bruisability, the skin is able to bruise easily. There is also high blood pressure. We will see what is the effect on the blood pressure. The skin will be thin due to protein metabolism. The red stee, the pendulous abdomen due to deposition of the fat, fat pads at the neck, we can say buffalo hump, and pendulous abdomen, same here, thin arm and legs, and poor wound healing due to protein deficiency. What is the effect of these corticosteroids on the electrolyte and water balance? Most important. What happened? The excess use of these corticosteroids will increase the sodium reabsorption. The sodium which is filtered in renal tubule will be reabsorbed and may be responsible for the hypernatremia. Hyper means increase, natremia means sodium. The sodium level in the blood will increase. With the sodium, there is molecule of the water. So sodium and water retention in the blood, which result in increase in the blood volume. Now, please keep in mind that with one molecule of the electrolyte, one molecule of water. If there is a retention of the sodium in the blood, the sodium will not come alone. It will come with the one molecule of water, and that's why the blood volume is increased. Increase in the potassium excretion. The potassium level in the blood is low, and the condition we can say hypokalemia. Hypokalemia. Decrease water shift from extracellular to intracellular. If you see the water from the extracellular to intracellular will be decreased, and this result in increase in the blood volume. And what is the effect of blood volume? If the blood volume is increased, it increase the GFR, filtration rate at the globulus, and which is responsible for diuresis effect, which is responsible for the diuresis in the adrenal hypofunction. What is the anti-inflammatory and before going to this, yes, there is one point in my mind. If there is a sodium is retained, sodium is retained, and the reabsorption of the sodium, what happened? Sodium retention. Sodium is responsible for increase in the blood pressure. Is the sodium is retained in the body, increase in the concentration of the sodium, we can say hypernatremia is responsible for increase in blood pressure plus increase in blood volume. We know that the corticosteroids having anti-inflammatory and immunosuppression effect. But how it is having anti-inflammatory and immunosuppressive effect? Now, this is the mechanisms. First one is it inhibits the phospholipase A2. What is PLA2? PL means phospholipase. A2, which is responsible to decrease the synthesis of inflammatory mediators, example prostaglandins and leukotrienes. So the inflammation in our body, in human body, is due to why? Is due to prostaglandins and the leukotrienes. If the synthesis of these prostaglandins and leu- the, the synthesis of the prostaglandins and the leukotrienes is decreased due to inhibition of the phospholipase A2 by the corticosteroid. So we are generally use the steroid in the for the purpose of the inflammation. How? Because the steroids inhibits the phospholipase A2. This is an enzyme. Phospholipase A2, an enzyme which is responsible for the synthesis of prostaglandins and leukotrienes, which are responsible for the inflammation. So if we inhibit the phospholipase A2, there is no synthesis of prostaglandins, no synthesis of the leukotrienes, and the no inflammation. Again, there is another mechanism. It also decreases the expression of COX-2. What is COX-2? COX-2 is a cyclooxygenase 2 and decrease the prostaglandin synthesis. No prostaglandins, no inflammation. Now, it is also used as in the allergic reactions. How? Because it decreases the antibodies formation and decrease the antigen antibody reactions. No antibody, no reaction with the antigen. No reaction with the antigen, no allergy. It is also acts as a stabilizer mast cell and basophil, which decrease the release of histamine and decrease the capillary permeability. No release of histamine, no allergy. Histamine is one of the mediators for the allergic reactions and the inflammations. Direct vasoconstriction when applied directly to the skin decrease the migration and function of the tissue macrophages and other antigen presenting cell, and it also stabilizes the lysosomal membrane, inhibits the proteolytic enzymes, inhibitions of the cellular immunity, and decrease the allergic reactions. So this macrophages, lysosomal membrane, proteolytic enzyme, cellular immunity, these all parameters are responsible for the immunosuppression effect. So this is about the anti-inflammatory and the immunosuppression effect of the steroids. What is the effect on the CNS? Long-term use of the corticosteroid may leads to initially insomnia. Insomnia, the person is not able to sleep, and euphoria. Euphoria is a condition of the well-being, feeling of the well-being. But a long-term therapy may leads to depression. It may leads to the depression. On the eye, there is a cataract. What is a cataract? Cataract is the vision is not clear. The person is not able to see clearly due to the lens is get opaque. The lens is getting opaque in the cataract. So that's why the vision is not clear, and which may leads to the blindness. What is the effect on the cardiovascular system? The long term therapy is responsible for the increase in the blood pressure. Now, how it is increase in the blood pressure? As we discussed, Hypernatremia, if the if the sodium level, natremia is not nitrogen, huh? It is sodium, please remember. Hypernatremia, if the sodium level in the blood is increased, it is responsible for the increase in the blood pressure. So in the hypernatremia, it sensitizes the adrenergic receptor in the blood vessels and the heart to catecholamines. Which are catecholamines? Adrenaline, noradrenaline, which is responsible for the vasoconstriction, increase cardiac output, increase blood volume, and these all effects are responsible for the increase in blood pressure. There is also direct vasoconstrictor effect. Due to direct vasoconstrictor effect on the blood vessel, which increase the peripheral resistance and which may leads to increase in the blood pressure. So the long-term use of the corticosteroids is responsible for the blood pressure. So when you prescribing to the corticosteroid to the hypertensive patients, you have to keep this point in the mind. Again, if you have to prescribe the drug, this drug to the person which is having the neuro psychiatric problem or problem to the eye, consider this point. It also responsible for the angiotensinogen formation. Yes, what is angiotensinogen? This angiotensinogen is responsible for conversion of angiotensin 1 to angiotensin 2, and angiotensin 2 is responsible for the vasoconstriction in the blood vessels. And if there is a vasoconstriction, it is responsible for the increase in the cardiac output and the blood pressure. There is also interstitial cardiac fibrosis, long-term use of steroid. The effect on the cardiovascular system include interstitial cardiac fibrosis due to direct mineralocorticoid action in the heart muscles. Anti-shock effect. This effect is very important in the life saving. We can see in emergency medicine. Anti-shock effect, as they increase the blood pressure, cardiac output in the shock, maybe septic shock, maybe anaphylactic shock. So if we see the treatment of the shock, the drugs are include adrenaline, noradrenaline, and also the steroids, prednisolone, because it increases the blood pressure and cardiac output. And in the shock, both are missing, the hypotension and decrease the cardiac output. So we have to take care of these two important parameters, hypotension and decrease in the cardiac output. So this prednisone, or we can say steroid, will increase the blood pressure. Now, how it is increase the blood pressure? By direct effect on the catecholamines and by storing the sodium, via sodium, increase the cardiac output. And also having direct vasoconstrictor effect, which increase the peripheral resistance. And if it is given with the dopamine in the treatment of the shock, and we know that the dopamine is the preserve the kidney functions. Dopamine stimulates the D1 receptor in the blood vessel, which is responsible for the vasodilation, increase in the renal blood flow, and increase in the GFR. Development of the fetal lungs. Yes, for the premature fetus. It stimulates the structural and functional changes in the lungs near term, including the production of surfactant required for the air breathing. When the delivery is anticipated before 34 weeks of the gestation, premature delivery. When the delivery is anticipated before 30 weeks of the gestation, premature delivery. And if in the premature delivery, the fetus is premature and the lung function is not developed properly, so at that time, the doctor will give intramuscular betamethasone. Betamethasone is a long acting steroid. The doctor will give intramuscular betamethasone 12 milligram followed by additional 12 milligram 18 to 24 hour to the pregnant lady. This injection not to be given to the fetus, or we can say the premature baby. I will read again. When delivery is anticipated before 34 weeks of gestation, premature delivery, at that time, the doctor will give intramuscular betamethasone 12 milligram followed by additional 12 milligram after 18 to 24 hours to the pregnant lady. What is the effect? It will increase the formation of surfactant in the fetus, in the lungs, and will prevent the neonatal respiratory distress syndrome. So if this premature label pregnant lady is not able to get this betamethasone injection, the baby may have, after the birth, the baby may have respiratory distress syndrome because the lungs are not developed well due to premature delivery. So betamethasone is used intramuscularly, is to be given to the pregnant lady, and it will we can say distribute via the placenta. The drug will distribute to the fetus via placenta, and it will prevent the neonatal respiratory distress syndrome. Now, why betamethasone is preferred? Betamethasone is preferred as it crosses the placenta to the fetus more than cortisol, and maternal protein binding and placental metabolism is less than of cortisol. We need the action. We need the action where maternal protein binding and placental metabolism is less than the cortisol. So we need the metabolize the drug not in the placenta. If the placental metabolism of the drug is increased, its adverse effect to the fetus is also increased. So why betamethasone is preferred? Because it crosses the placenta and its metabolism in the placenta is less as compared to cortisol. So this question may be for your MCQ. Which of the following, we can say 34 weeks of the gestation pregnant lady, and for the prevention of the neonatal respiratory distress syndrome, which of the following drug might be useful? So remember, betamethasone. What is the effect on the hematology? Hematological effect. blood. WBC's single dose of short acting glucocorticoids increases the PML. What is PML? Polymorphonuclear leukocytes in the circulation. Due to the increased influx of this polymorphonuclear leukocyte into the blood from the bone marrow, decreased migration from the blood vessels, decrease adherence to the vascular wall, and decrease the number of these polymorphonuclear leukocytes at the site of inflammation. It also causes a decrease the concentration of lymphocyte, T lymphocyte and the B cells, monocytes, eosinophils, basophils in the circulation due to their movement from the vascular bed to the lymphoid tissue. And these changes maximal at 6 hours and this dissipated in 24 hours. What are the other actions on the RBC? Stimulate the erythropoiesis, increase the RBCs, increase the platelets, increase the blood coagulation, destruction of certain lymphoid malignancies. We will discuss in the hematology block, in the heme block, the blood induced hematological disorders. And in that blood induced hematological disorder, the long term use of the steroid is one of the trigger for the blood induced hematological disorders. So overall in the blood, what is the effect on the blood for the WBC? You can say it increases the polymorphonuclear leukocyte, increase the RBC, increase the platelet, and increase the blood coagulation. What is the effect on kidney? It increases the uric acid excretion. So can be used in treatment of gout. In the treatment of gout, it can be useful because it, but not in the long term and not in the high dose, please. And it also increases the calcium excretion and used in treatment of the hypercalcemia. But it is not clinically, we cannot, it is not approved clinically in the treatment of the gout and the hypercalcemia. So it is just pharmacological effect, but not approved legally to be used in the treatment of the gout or treatment of hypercalcemia. On kidney, it is having very bad effect. There is one case now, just last week, um, one person, I think it is 30 to 35-year-old person, and to build up the body, he started to taking some steroids to build up the body because due to anabolic effect. Some are using to build up the body steroid, but what happened? His two kidneys are failed due to use of the steroid injection to build up the body. He is going regularly to the gym, and now his two kidneys are failed due to the low high dose and the long term use of the steroid to build up the body. So on the kidney, the function of the steroids are uh, maybe leads to the acute kidney failure and may leads to the chronic kidney failure. So on the kidney, if it is mentioned here that it increase the uric acid excretion, so can be used in treatment of gout? No, never. Can be used but not approved. And it increase the calcium excretion, so it cannot be used in treatment of hypercalcemia. No, never. Not approved by the FDA. On the GIT, peptic ulcer, in the large doses, it may lead to peptic ulcer by suppressing the local immune response against Helicobacter pylori and decrease the prostaglandin synthesis. So if it is used in the large dose, may cause the peptic ulcer. Antiemetic effect, may be due to the decrease in the 5-HT. What is 5-HT? 5-hydroxytryptamine, that is serotonin release. Antagonize the 5-HT3, HT hydroxytryptamine, serotonin, or activate corticosteroid receptor in the nucleus stactus solitaris of the medulla of the CNS. So it is just having the antiemetic effect, but not used, because these are the pharmacological use, not clinical use. So please keep in mind. On the growth retardation in the children, partially prevented by the growth hormone. So long-term use of the steroid may lead to the growth retardation and inhibits the hypothalamo pituitary axis, because you know that this is a negative feedback mechanism. If we take this steroid from the outside, synthetic one, so and this our blood plasma level of the steroid is maintained by the outside synthetic steroid, so our natural endogenous hormone will not able to work, they will sleep. Because what is the signal to the our natural endogenous hormone? What is the signal? The signal is that the blood having the sufficient amount of this steroid, so don't secrete, and it will inhibit the hypothalamo pituitary axis, decrease the release of adrenocorticotropic hormone, growth hormone, thyroid stimulating hormone, and luteinizing hormones. All hormones get sleep, because what is the message? Negative feedback mechanism. The amount of the steroid by the synthetic origin or by external use are enough, no need to work, slip down. So these are the long term use, these are the pharmacological actions when anyone use the long term or in high dose the steroids. On the bone, what is the effect on the bone? Osteoporosis. The we seen this, it is a catabolic effect. Osteoporosis
Doctor,
due to decrease bone formation by inhibit osteoblast, decrease the bone
doctor,
matrix, just 2 minutes, decrease the bone matrix, osteoid tissue by their catabolic effect, and decrease the bone mineral. How decrease the bone mineral? It will cause increase the calcium excretion in the urine. So calcium from the bone is excreted in the urine, decrease the calcium and phosphorus absorption from the intestine. So this is the effect by um, this is the pharmacological actions on the bone. There is also decrease in the secretion of the luteinizing hormone, and you know that the luteinizing hormone is responsible for the estrogen production. So luteinizing, if the luteinizing hormones are decreased, decrease the estrogen production in the women and the testosterone. And if the deficiency of the estrogen, obviously there is osteoporosis. Increase the bone resorption by the osteoclast. Osteoclast means breakdown of the bone, and changes in the production of the osteoprote, os, osteoprotegerine and the rank ligand, which is responsible also for increase the PTH, that is increase in the parathyroid hormone, and which is also responsible for the bone resorption.